All right, today we're going to dive into something pretty fascinating. We are connecting the dots between two lung conditions that might seem separate but are actually deeply linked: bronchiectasis and cystic fibrosis. So let's just jump right in with a question that, I'll admit, sounds a little weird. What in the world could possibly connect salty skin to a really nasty chronic cough? It seems random, I know, but stick with me. By the end of this, you're going to see exactly how these two things are linked. It's pretty wild.
You know, every good investigation has to start somewhere, right? So we're going to start with the symptom, the thing a person actually experiences and what a doctor sees first. So let's meet our first key player, bronchiectasis.
So what is this exactly? Well, bronchiectasis is a long-term condition where the airways in your lungs, those are called the bronchi, they get permanently widened. You can almost think of them like pipes that have been stretched out and damaged. Because they're misshapen, they just can't clear out mucus the way they're supposed to. And that leads to this gunk building up. And that's where all the trouble really starts.
What's so cool here is watching how doctors become detectives, They're piecing together all these little clues. They might see a patient who's underweight or notice that nonstop cough. But there are also these really specific physical signs, like clubbing of the fingers, where the tips get all swollen and round. A doctor might literally feel a rattling vibration in the chest, or when they listen with a stethoscope, they hear these very distinct coarse crackles.
And get this. This is one of the biggest diagnostic clues right here. When a doctor listens, they might hear coarse inspiratory crackles, which change in character by coughing. Okay, in plain English, the crackling sound they hear actually changes after the patient gives a good cough. Now that is a huge tell. It lets the doctor know that the noise is being caused by mucus moving around in those big, wide airways. It's not a fixed problem like scar tissue.
Okay, so we've pretty much nailed down the what. Now it's time to figure out the why. Let's keep this investigation going and see if we can uncover the root cause.
And this brings us to a really important point. Bronchiectasis usually isn't the main problem. Nope, it's often the result of something else going on deeper down. So the real million-dollar question is, what's the underlying cause?
And here is where things get really complex for doctors. I mean, look at this list of suspects. It could be damage left over from an old infection, like tuberculosis or even measles. It could be connected to things like COPD or even lung cancer. Then you've got these rare genetic syndromes and, you guessed it, the one we're really going to focus on today, cystic fibrosis.
With so many different possibilities, let's zoom in on one of the biggest culprits out there, just so we can really get how this all works. It's time to put cystic fibrosis in the spotlight.
Cystic fibrosis, or CF for short, is a genetic disorder. It's what they call autosomal recessive, which basically means you have to inherit one copy of a faulty gene from both of your parents to get the condition. And the problem is super specific. It's a flaw in the CFTR gene, which sits on chromosome 7. This one gene is supposed to be the instruction manual for a tiny little gate in our cells called a chloride channel.
This chart shows you exactly where it all goes wrong. On the left, you've got a normal channel. It lets chloride, which is just part of salt, move freely in and out of our cells. That process keeps the mucus in our lungs nice and thin. But look at the right side. That's the faulty CFTR channel. It traps the chloride inside the cells. This mess-up draws water out of the mucus, making it super thick and sticky, which, you guessed it, clogs up the airways and leads us right back to that bronchiectasis we started with.
And believe it or not, the effects of this one bad gene go way beyond just the lungs. I mean, these channels are all over our bodies. So CF can cause a whole host of other issues, like short stature, problems with the pancreas, diabetes, and even infertility. It's a full-body condition, and it all traces back to one tiny little genetic typo. So with that long list of possible causes, how do the medical detectives actually confirm what they're dealing with? Let's take a look at the diagnostic work they use to finally crack the case. Medical imaging is huge here. It gives doctors these incredible visual clues. Radiologists even have these really descriptive, almost poetic names for what they see. A honeycomb appearance looks just like it sounds, a cluster of cysts. Tram lines are these parallel lines that show the airway walls have gotten thick, just like a set of train tracks. And the signet ring appearance, that's a classic. It's where a widened airway sits right next to its blood vessel, and together they look just like a ring with a stone on it.
Now, to really get the full story, doctors have a whole toolkit of tests they use. A chest x-ray might show those tram lines, but they really need a high-res CT scan to confirm that signet ring sign. And to nail the cystic fibrosis diagnosis, and hey, here's the answer to our first question about salty skin, they do a sweat test. See, because those chloride channels are broken, a person with CF will have really, really high levels of chloride in their sweat. It's a dead giveaway. After that, they can do other tests to see what bacteria are causing infections or to check for breathing blockages.
It's also so important for doctors to be able to tell bronchiectasis apart from other conditions that might sound similar, like lung fibrosis. The treatments are totally different, so getting it right is crucial. And the clues are all in the little details. For bronchiectasis, the crackle sound is coarse. For fibrosis, it's fine. And here's the big one again. In bronchiectasis, the crackles change when you cough because that mucus is moving. In fibrosis, they don't change at all. It tells the doctor exactly what they're up against.
And the job isn't done once the diagnosis is made. Doctors then have to look for any serious complications that can pop up over time, and some of these are really serious. We're talking about things like respiratory failure, high blood pressure in the lungs, and even a condition called cor pulmonale, which is a massive strain on the right side of the heart.
Okay, we've got a diagnosis, we understand the cause. So what do you do about it? What's the response? How on earth do you manage something this complicated?
Well, the treatment strategy is kind of layered, with 3 main tiers. Step 1 is the foundation, things like specialized chest physiotherapy to literally help shake that thick mucus loose. Plus, quitting smoking and getting all your vaccinations are non-negotiable. Step 2 brings in the pharmacy, antibiotics to knock out infections, bronchodilators to help open up the airways, and steroids to calm down inflammation. And finally, for really severe cases that are just in one part of the lung, Step 3 can include surgery, sometimes even going as far as a full lung transplant.
So if there's one thing to take away about treatment, it's this. At the end of the day, the entire approach is built on 2 main pillars. First, treat the underlying cause if you possibly can. And second, be super aggressive about managing the infections that just love to grow in all that built-up mucus.
And that brings our whole investigation right back to the beginning. We started with a symptom, a chronic cough, and we followed the clues all the way back to a single faulty gene that messes up a tiny channel in our cells. It's just an amazing piece of medical detective work. And it leaves us with a really big question for the future, doesn't it? If we can trace a condition like this all the way back to its genetic source, what does that mean is coming next?